started here. And up today is a hearing on Senate Bill 440, and we'll hear from Revisor Abbott.
Thank you, Madam Chair, and good afternoon, members of the committee. Senate Bill 440 comes to you from the Senate Committee on Public Health and Welfare. The bill would amend current law governing the practice of occupational therapy. Under current law, the practice of occupational therapy is performed pursuant to the referral by a physician or other healthcare providers. The bill would eliminate that requirement in certain circumstances. So in Section 1 of the bill, at the beginning, you'll see that it provides that an occupational therapist may evaluate and initiate occupational therapy without referral from a healthcare practitioner, as is required under current law. It does require the occupational therapist to receive referral from a physician or other healthcare practitioner under certain circumstances. The first of which, if the person is not progressing towards documented treatment goals, or in a period of 30 calendar days from the initial treatments following the initial evaluation visit, or within 1 year from the initial treatment visit, they return to the occupational therapist seeking treatment for the same condition or injury. The bill also specifies who an occupational therapist may provide services to without a referral. Those are employees for workplace injury prevention purposes, the public for health promotion, education, and functional independence and activities of daily living, and special education students who need occupational therapy services to fulfill the provisions of an IEP or IFSP. The bill clarifies that the bill would not prevent a hospital or ambulatory surgical center from requiring a physician at that hospital from requiring that they make a referral for occupational therapy services. The bill also requires occupational therapists who are providing services without a referral from a physician or other healthcare practitioner to disclose to the patient that the occupational therapy diagnosis is not a medical diagnosis by a physician. The bill would also limit occupational therapists in their performance of wound care management to only occur after approval from a physician. And then the bill would make some technical updates to the current Occupational Therapy Practice Act to conform to that. Section 2 of the bill would add a professional liability insurance coverage requirement for occupational therapists as a condition of rendering professional services in this state, and delegates to the Board of Healing Arts to establish rules and regulations, the minimum level of coverage for that insurance coverage. The bill would also clarify in the definition of the practice of occupational therapy that the practice does not include the practice of any branch of the healing arts or the making of a medical diagnosis. The bill will take effect upon publication in the statute book on July 1 of this year, and I would be happy to stand for questions.
All right, committee, are there questions? Representative Turner.
Thank you, Madam Chair. I don't have a great background in healthcare, but you mentioned the word wound care management, and occupational therapists, in my understanding, aren't typically in the wound care business. But is that term defined somewhere in the definitions here, or is that just a universally known term that I'm not familiar with?
Yeah, Madam Chair and Representative, I don't believe that term is currently defined in the Occupational Therapist Practice Act. The definition section of that act is in the bill. That's the Section 4 of the bill, and I don't see it anywhere. I would interpret that provision as just a general limitation on their scope of practice under these new provisions.
Thank you, Madam Chair.
Are there further questions? Scott, I guess one that I have, and this may come when we're talking to conferees, but looking at, you mentioned the IEPs, and so I'm wondering is there anticipation that this is going to be covered by insurance or that the schools are going to do it with services within the school, which is required under the IDEA Act?
Madam Chair, I would not know that off the top of my head. I can look into it, or maybe one of the conferees knows.
Yeah, let's see if the conferees come up with it. So there'll be a few more of those questions. Committee, further questions? Representative Reese?
Thank you, Madam Chair. I think it kind of goes along with what you were asking. I'm wondering about insurance coverage for this when you're not have a referral from a from a physician.
I think, and we'll hear from the conferees, but it's my understanding that this bill was based on language from the physical therapist bill that was passed several years ago that gives direct access. So it's like if I decided to go and it's a coverage that my insurance normally pays, they're going to pay for that, just like they do with a PT. That's my understanding. Keep in mind, I'm not the expert. I'm not an attorney.
Thank you, Madam Chair.
We can't hold Scott liable if he misleads us, any of that kind of stuff. Are there any further questions? I don't know if Scott's insured or not, but we'll protect him. He's a good revisor. Thank you, Scott. He can do wound care? Travis, I think we need to talk to the doctor here, I'm just saying. All right. Committee, we have one proponent, and Travis, I am bad on your last name. Travis? Grauer Holtz? Is that right? Okay. Welcome to committee, and this is on behalf of the Kansas Occupational Therapy Association. Welcome to committee, Travis.
Thank you. Appreciate the candy.
That's why I
here.
only say Travis.
No, perfect. Yes, as Chairwoman Landwehr mentioned, my name is Travis Grauer-Holtz, appearing on behalf of the Occupational Therapy Association. We've referred to it as KOTA, so you'll hear me in my testimony refer to it as KOTA, but that's what it stands for. KOTA was founded in 1972. It consists of over 450 occupational therapists, assistants, and students. I want to thank you for the opportunity to provide testimony today on Senate Bill 440. Over the past year, we had many internal discussions within KOTA on how we could provide better services to individuals in the state of Kansas. We believe that these updates to the OT scope of practice will allow us to do so. Currently in Kansas, OTs are not allowed to offer their services to individuals without a licensed healthcare practitioner referring them to do so. We believe, the bill would change this process and allow the OTs to offer those services without that referral. In those 3 instances that Scott already mentioned, I'll go through those again. Employees, for the purpose of education, instruction related to workplace injury and prevention, special education students who need occupational therapy services to fulfill the provisions of their individual education plan, that's the IEPs that Chairman Landwehr was talking about, and individualized family service plan, and to the public for the purpose of health promotion, education, and functional independence and activities of daily living. Those activities are the bare necessity activities that we need to do every day in order to survive. I want to be clear, this does not completely eliminate that referral process. There are some checks and balances in the bill. Those include, 10 patient visits and 30 calendar days. If that individual that is getting those services from the OT is not progressing towards documented goals, that referral would kick back in. If a patient comes back seeing the OT with the same issue after a year, again, that referral will kick back in to make sure that there's any underlying conditions that the OT is missing. Another change the bill does is adds in the requirement for OTs to maintain liability insurance to be licensed in the state of Kansas. Currently, OTs and OTAs are not required in the state of Kansas to hold liability insurance. However, it is strongly recommended and highly practiced right now within our association. Within the insurance, it's not our intent, and maybe this will answer a few of the questions that were asked earlier. It's not our intent to make any changes in the manner in which OTs are reimbursed by health insurers. We don't identify any provisions in the bill that would require insurers to change reimbursement rates or practices. Lastly, the bill adds in the ability for OTs to perform wound care management, but this is only after the approval by a person's licensed to practice medicine or surgery. We believe these changes will benefit all Kansas. A lot of the conversations that we had were more based on the western side of the state. Our individuals were having to wait, hours to get the OT service. We believe that this would at least fast track in those 3 instances to allow them to get those services quicker. Before I wrap up my testimony, I want to thank both KMS and the Board of Healing Arts for their role and input on helping us craft this legislation. While not all concerns may have been addressed, we believe it is good compromise between all of us. We respectfully ask for support on Senate Bill 440, and I'd be happy to stand for questions at the appropriate time.
I think what we're going to do, Travis, being all we've got is you and then, of course, Courtney Seisman with the State Board of Healing Arts, and then we'll go into questions all at the same time.
Okay.
All right, thank
Awesome.
you.
Thank you.
All right, Courtney, General Counsel with the Board of Healing Arts, welcome to committee.
Thank you, Madam Chair. My name is Courtney Seisman, and I'm General Counsel of the Kansas State Board of Healing Arts. And thank you for the opportunity to present testimony to you today regarding Senate Bill 440. The Board of Healing Arts is the executive body that's tasked with licensing and regulating 16 different healthcare professions in Kansas, including occupational therapists. I also want to echo what Mr. Grauerholt said. We really appreciate the collaborative effort that KOTA has taken with the board with respect to this bill. There's four main concerns with the board as it relates to patient safety. So the first is in new section 1. As written right now, it indicates what you do when the patient is not progressing. However, the board would request clarification on what you do when the patient is progressing. In new section 1, subsection A1B, the board is concerned that if a patient returns to an occupational therapist for the same disease or injury at all, regardless within 1 year, that at that point you would need a referral from a physician because there's concern that maybe something else is going on medically that needs further evaluation. And third is a definition of wound care management would be really helpful for the OT, for the patient, and for the physician who is approving the OT to do wound care management. It's important that the OT know what's within their scope in terms of wound care management. It's important for the patient to know, hey, I can go to my OT for this, or no, I actually need to go to my physician. And then it's important for the physician to know what they're actually delegating or approving the OT to do. And then finally, the board would request an inclusion of a primary care provider notification, just simply letting the primary care provider know that their patient is receiving OT services for purposes of continuity of care. And I'm happy to stand for questions at the appropriate time.
All right, thank you very much. All right. Committee, then you will find in your information a written only from Rochelle Colombo, Executive Director of Kansas Medical Society, as neutral. Was there anyone else that thought they had signed up and I did not call on them? All right, we did good today. Questions Committee, Representative Epley.
Thank you, Madam Chair. This would be for Travis, if he could hop back up there. So, Travis, we appreciate, again, the work you put into this and all the information you provided. If I had to distill this down, is this very similar to what we already have as far as a template with physical therapy in the state of Kansas?
Travis Grauerholtz, Kansas Occupational Therapy. Yes, that is correct. We viewed the PT language as a model and kind of tweaked it to satisfy some of the OT's needs that they have.
And just to share with the committee, as a provider that utilizes OTs every week at least, it's been free-flowing with my PTs in this situation, and there hasn't been any problems in treatment and care with physical therapy. And this sounds like this would be an analogous situation then for occupational therapy as it's set up in this bill. And so then that leads me to the last thing that was brought up by Courtney and Ms. Seisman of the General Counsel of BOA, and that was wound care definition. Do you think that would be hard for us to get a little technical amendment that would define that for us?
We worked closely with KMS on that language, went back and forth with them quite a bit on, you know, what they could accept, what we could accept, and that was kind of the agreed upon language. I believe our initial language may have went into a little bit more detail, but I think that kind of boxes an OT in, and want to make sure that we're not, you know, allowing that OT to not do something that they, you know, that the physician is referring them to do.
So the language right now is certainly acceptable for you, and it sounds like the board's neutral on it, but they'd like a little more definition. So, okay, thank you.
Representative Lynn.
Thank you, Madam Chair. My question is probably also for Travis. And is wound care management actually defined in the bill? I can't find it.
No. No.
It's not?
No.
Okay.
Nope.
Then one of my questions then goes to page 2, line 4, where it talks about approval by a person licensed to practice medicine and surgery. Would it be better if we were to, instead of having a person licensed to practice medicine and surgery, maybe be the patient's established physician for that surgical wound or whatever that was, as opposed to anyone who is licensed to practice medicine?
Again, that language was kind of agreed upon language between us and KMS. That was their language they wanted to see in the bill. So I can circle back with them and see if they would be comfortable with that. We, again, went back and forth quite a few times on that language and ultimately accepted their last proposal.
Okay.
Well, and I think, and I'm going to add in, keep in mind, I'm not an expert at all of this, but what I'm thinking is you may have someone that wasn't dealing with a primary care physician, so it was an ER situation. So, but then they decided that they wanted to do occupational therapy, so they go to an OT, and then that wound is dealt with there if it has to be. I think that's, so you don't want to box it down too tight. We got to remember not everyone has. Or even if you do have a primary care and you went to the ER, your primary care wasn't involved with the wound that you're dealing with.
Well, I wonder if maybe the ER doctor in that example would be the one that says, okay, yes, somebody else can take care of this wound management.
Well, they could, but I don't know how practical that would be in going back to the ER doc.
All right, thank you.
Dr. Epley?
No.
Okay.
You're doing great.
All right. And that's just, food for thought. Doesn't mean we don't take a look at it, but Representative Berquist.
Yes, Travis, before you get completely set back down. Yeah, I believe in the introduction, we heard that the requirement for letting the individual know that the plan that to be engaged in was not prescribed by a doctor. Would that be in the written in the form of a treatment plan that's presented to the individual, or how would that be done? Just verbally or written?
That, are you talking about this section where it says it is not a medical diagnosis?
Yeah.
Where's that at in the bill? Page 2? At the top?
Yeah, I'm just curious if it'd be if you're going to present a written plan anyway to the individual for the next so many weeks, if it would also be stated that it was either was at the instruction of a doctor or not.
If the service they're receiving was provided by a doctor, is that the question I'm understanding?
If it was not, if it was just from the occupational therapist, that you would state that this is not at the directive of a medical professional.
Okay, I don't believe we have that in the bill, but I can dig through it.
Thank you.
All right. Next, I have Representative Blex.
Thank you, Madam Chair, and thank you, Travis. My question's for you. Looking at a patient that comes in on a non-referral, without a referral, and looking at the treatment goals, they've got to be objective, measurable, or functional improvements, or a combination thereof. And 10 patient visits or in a period of 30 days from the initial treatment following. I mean, to me, I guess that sounds a little confusing. How's the patient going to kind of understand that? Is there going to be something written up front? In other words, to me, if you say, well, I can't look at you now because of this, one of the triggers deal, it makes the OTs look a little bad. You know, like, I can't do my job. You got to go back for referral, and I see some problems there. How do you see that working?
I mean, I think that's the agreed upon language we came across was, the OT can see in those limited manners, and if it doesn't fall within those three scopes there, that they can see that they will have to provide that. So it will fall back on the OT to make sure that the scope is followed completely.
And that would be something that would more than likely, I assume, and be up front with the patient. They would know that in advance, that prior to them maybe submitting to a second treatment or even the first one, I guess.
Correct, it would be.
Okay, thank you for that. Thank you, Madam Chair.
Travis, and maybe you don't know this, but I know Revisor Abbott can find it. Do we deal with wound care at all in the PT bill?
I believe they don't have wound care management. I believe it's wound care debridement, but don't
Okay.
quote me on that.
That's right. We'll have Scott look it up. So thank you. Representative Reese?
Thank you, Madam Chair. Is the location of practice defined?
It is not, no.
Is there a need for that?
I don't think so. But maybe leave that up to the will of committee. An OT will probably open up a shop, and we do have OTs now that do have standalone shops, but they cannot operate without the referral of a physician.
Okay. So we're talking about occupational therapists that go to the homes?
Correct.
Okay. This is why I like the wound care management services. And I can imagine, I've got many friends now that live out in western part of Kansas, and knowing their medical services, how they partake in medical services, and wanting to just kind of take care of things on their own. I don't need to go drive it to Hayes to have a doctor take care of my wound. And knowing that they have an OT in their home, I'm sure they'll say, look at this, or can you help me with this? And I think that's just another set of eyes on that wound too, that I think is very valuable.
And I want to, Madam Chairman, if you don't mind me responding, I want to make sure that it's understood that in that situation, if they don't have the referral to look at that wound, they cannot, deal with that wound. They may be able to pull it up and say, look what I have here. And that OT goes, I need you to go to a doctor and get a referral before I can go through.
Yes, Madam Chairman, if I may, I think in that instance, it's awesome because the OT can maybe speak to the doctor and say, this is what I'm looking at.
Yeah.
And have more descriptive words, I guess, to describe what they're looking at.
Thank you.
Thank you.
Representative Turner?
Thank you, Madam Chair. See, I'm missing one piece here. So absent the referral, what is the onboarding process where I get hooked up with an occupational therapist? Do I just self-assess that I need one and go, or could you explain that?
Yep, and I'll explain it to the best of my ability. I have with me our Government Affairs Chair who is practicing in the OT world right now. Correct me if I'm wrong on anything. So the way the process would work if this bill was to pass is that an individual would go see an OT. They would evaluate that patient and ultimately, decide if it's a referral process that would need it or if they could see them if it falls within those three categories. If that referral process comes in, then they would just kick it off.
But how does that first visit even take place? I have to just make a phone call and say, I think I need your services, I need to be evaluated? Is that the step?
Correct.
And then, sorry, Madam Chair, does that, I'm assuming these are covered by insurance, so can I then file a claim? It seems like my insurance company would want some assurance that I actually needed these services before they would reimburse me.
Yeah, our intent is to keep insurance the exact same as it is now with the referral process. If an OT sets up a shop, they would have to contract with, get part of the network of the insurance provider. So to make sure that the services that are being provided are covered under insurance.
Initial visit where I go, I've self-assessed that I think I need this, and I make an appointment, and then I go. I can still turn that into insurance, and they'll be good with that. Is that your view?
If you don't mind, I might turn to Heather to answer, maybe to have it.
Just tell us who you are so it goes out on the web.
My name is Heather Wright. I am a certified occupational therapy assistant and certified lymphedema therapist. And answer to your question, could you repeat the question for me?
Well, I was trying to establish, absent the referral process, how do I get linked up with an OT? And it sounds like I can just reach out. I would say yellow pages, but I'd be showing my age. So I could find one and make an appointment, then I come in and you do an assessment of me to decide whether or not I need treatment and you can help me. Is that fair? And I can turn that into my insurance. What my own mind thinks, okay, well, is that an insurable visit? Since I've made my own decision that I need to come.
Sure.
Thank you.
We would do an evaluation so that there are certain tests that we would perform depending upon what your injury was. So from there, we do documentation for those services like what we do in our visit. And so that would be submitted to the insurance. Now, insurance could say, no, we don't think that could be covered. So they could, deny the visit. But in making the appointment, usually in whatever facility that we're working with or in, would ask some questions to make sure that it would be a visit that we would want to see. If that answers your question.
Yes, thank you, Madam Chair.
Representative Lynn.
Thank you, Madam Chair. I have a question that maybe Representative Epley can help me with. It's just a general question about wound care. If that is meant to be, when you're talking about wound care, is that just superficial, or does it include, someone who's had like pins inserted? I don't know who can answer that.
Do you want to, or you want to let her? You're doing it now, right?
Okay, that's fine.
So wound care management can depend on the wound, obviously. Most of our wound care management that we perform is for educational purposes. So we're treating the patient, they come in, they have a wound, we see it, this is how you take care of it, where have they come from, have you talked with your doctor? We do assessments to see if it's hot, if it's red, if it's oozing, those kinds of things. So from there, if it is something that we feel is out of our practice, if we are worried about an infection, we will contact the physician.
So it's mostly the, like the incision site. I wonder how do you find out, let's say a patient has had multiple pins inserted into their hip. What's the normal process for dealing with that? Because you would want to know that to make sure that the therapy is appropriate, I'd imagine.
Yeah, I think that's really something that I don't deal with daily. But some of my colleagues do sutures. They are kind of used to taking care of those types of things, dressing changes. So those are some of the things that we normally see that wouldn't be abnormal. So the only time that we would be apprehensive to treat that patient would be in those cases where there's a risk of infection. So red, hot, that kind of thing.
Okay, thank you very much.
Well, I would kind of think that, if they were coming in to, well, first of all, let's ask the question and get clarification. The difference between an OT and a PT.
Oh, that's a good question.
The
Thanks
fine
for
line,
asking.
isn't it?
That's an awesome question. So the difference between an occupational therapist and a physical therapist is we treat different things. Occupational therapists can work in a range of different areas. IADLs, ADLs, so dressing, bathing, toileting, feeding, all of those type of basic activities. We also work with patients, just rehabilitation for cognitive, mental health, illness, children in schools, physical therapy. Don't quote me on what they are generally, but they are mainly for mobility and different things with joints of the lower extremities.
Right. So I think maybe the scenario that you were talking about, that individual is going to be at a PT having that work done after a hip surgery, or if you have rotator cuff surgery, that type of stuff.
It could be.
Okay. I have Representative Wolfmore.
Thank you, Madam Chair. That definition helped a little bit
Yeah.
because I was wondering, workplace injury sounded more PT, but I guess there'd be all kinds of workplace injuries,
Yeah.
carpal tunnel, all kinds
Right.
of things like that.
Yes.
I'm still kind of following up on Representative Turner's question was sort of my question. So a workplace injury, for example, if you don't go to the doctor, how do you know that you need to go to the OT, or how do you get connected? I'm still kind of struggling with that a bit.
Sure. And we could work off of referrals as well. So if there's a question from that person, they would probably already have gone to see their physician. And with workplace, work comp issues, they would probably be required by their workplace to go see a physician first. So it depends on the person and what their injury is. If they have knowledge of occupational therapy in the past, they could say, okay, well, I know the occupational therapists that I've worked with in the past, they have dealt with this and they know, about this. I will just go to see them. And that might be how it would work.
Okay, I guess it's a matter of educating the public, just like it probably was with the PT bill.
Yeah.
So thank you, Madam Chair.
Well, and I'm kind of thinking along the lines when you brought up like carpal tunnel, being a layperson, I'd think, I probably need physical therapy, but a physical therapist may want to refer you to an OT.
Exactly.
So, committee, are there further questions or comments? Representative Eppley.
Well, thank you, Madam Chair, just to address some of the concerns. When you think of OT, I think of fine motor, and maybe that's more traditional interpretation, but fine motor of your hands and of your feet as opposed to, and PT does more gross motor with large movements, and so there's a big difference there. And PT and OTs really do work very collaboratively together, particularly on stroke rehabs. You see that all the time. And as far as wound care, what's great about an OT seeing wound care day after day is they can schedule the appointments, do the dressings, and then if something isn't going well, they can refer back to the primary care physician. But a lot of your primary care docs or APRNs or providers or whatever, they may not have the capacity to see that patient daily or every other day, whereas if the OT is seeing them, they can see either the subtle improvement or the lack of improvement and the need to go back, and they can advocate for that patient. And that happens in the real world a lot. There's just so much parallels then finally with how this works as it relates to PTs in this bill and the work that's gone into it. So, I think it's been pretty well processed with the Board of Healing Arts and with the Medical Society, where people are at peace with this at this time. But, I think the relationship between OTs and providers, APRNs, physicians, whatever, is pretty collaborative, and this is just to allow more direct access going forward.
Committee, further questions or comments? Representative Turner.
Thank you, Madam Chair, for an opportunity to have a second question. In following up to Representative Eppley's questions, you said everybody was at peace with this. And Travis, while you're up there, I guess I could ask the other, but also, were the other folks, because some of the things that were on the list that we heard from the other testimony seemed fairly reasonable, like letting the my general doctor know, and I don't know if that was my question to him, if he would want to know that one of his patients is going and getting therapy. So that seems like a reasonable suggestion, or even defining the wound. So did they have a seat at the table, or why is it that they still have some things here that they've brought to testimony? Thank you.
Yeah, no, appreciate the question. Thank you. They definitely had a seat at the table. We worked very closely with them, went back and forth quite a few times. They had quite a few suggestions after we met with the board. We implemented the ones that we were comfortable with. We're happy to continue to have discussions on the other ones.
When would those continued discussions happen, I guess? If it didn't make it into this bill, you decided that it wasn't a good idea to define wound management, or it wasn't a good idea to advise the general care doctor. Thank you.
I can, if you, Madam Chair, if you don't mind responding. It's not that we didn't think they were good ideas. We just didn't think on our side that it was a necessary thing. A lot of our OTs are already in touch with primary care doctors. We didn't see the requirement to put it in the bill that they have to do something that they're necessarily already doing right now.
Okay, thank you, Madam Chair.
All right, thank you. Committee, are there further questions or comments? All right, Courtney, do you mind stepping up and answering some things? I think where Representative Turner was going, and it's something that I want to make sure that we resolve, is that you had some concerns in your testimony. Are these the concerns you still have today?
They are, yeah. And
Okay.
Courtney Sisman, General Counsel of the Kansas State Board of Healing Arts. Yes, they are, Madam Chair. And these were concerns that were raised at the December 2021 board meeting when KOTA came before the board with, at that point, the proposed legislation.
Okay, so then have you guys given thought to, well, let me ask Travis, just stay up there. I'm going to bounce back and forth between the two of you. So Travis, had you seen these prior to drafting your bill and making the tweaks and everything else? Had you seen all these?
We did, yes.
Okay, so these were ones that you chose not to put into your bill?
That is correct.
Okay, all right. So now back to Courtney. Have you looked at how that language should be drafted if we were to adopt any of these and put them into the bills?
We have not taken that step yet, no.
Okay. Is this something that, and I guess we just need to hear from our committee members if there's any of these that they feel like should probably be in the bill? So then would you be opposed to the bill if we passed it without these amendments in it?
We are not, we're neutral.
You're just neutral on it? Okay. All right. Thank you very much, Courtney. Are there any further questions? All right. Committee, is there any objection to working this bill? All right. Seeing none. Representing Epley.
Madam Chair, I'd like to move that the committee pass Senate Bill 440 out favorably for passage.
Is there a second? Second. Seconded by Representative Kelly. Questions, comments on the motion? Representative Epley.
Thank you, Madam Chair. I appreciate, the comments here today, and I've worked with OTs every day, and not every day, but frequently every week, and there is good collaboration with our OTs in our particular situation. I think that's pretty uniform, and when they recognize a problem, they call it to our attention. I don't know how far we need to get into definitions of wound care. I mean, I appreciate the concerns. I think you need to at least delineate that they're going to do that. I don't know if you start trying to describe all the different types of wounds that relate to post-op wounds, to diabetic ulcers, to foot ulcers, to cellulitis, to phlebitis, I mean, it can get pretty crazy. So I'm comfortable with the language as it appears currently in this bill, and I just want to say I think it's obvious from the testimony. I think we're at a pretty good place on this bill. Thank you.
All right. Committee, further questions or comments? And, one thing to keep in mind is if we were, as we go through this process, because I know when we went through the physical therapy bill, we were going to have people die. And you do have to remember that these are health professionals. They are carrying their own liability insurance. And I think it's only a bad actor. We know that in any profession you have bad actors that would risk their license. Yeah, there's bad actor doctors too, Representative Epley. Every profession has them out there. So we haven't had a lot of the bad things that were predicted with our PTs, and I think this will take and move us forward, and if things come up later on, it's something that we can fix. So further questions or comments? Seeing none, Representative Epley, you may close.
I close.
Okay, you've all heard the motion by Representative Epley to pass Senate Bill 440 favorably. All those in favor signify by saying aye.
Aye.
Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. Bill passes. All right, committee, that's all we had here today. You recall yesterday we sent two parties back to see if they can't come to a compromise on a bill. And I expect to see that language on Monday. And if it is something that we feel like the reviser can work with quick enough and we can go into a meeting on Monday, we will meet on Monday. We have, there's still a couple of bills coming over from the Senate we're going to keep our eyes on. What was this one? Oh, did we get this one? Okay. It looks like okay, so we're going to have House Bill 2734 that just got appointed to our committee. And this here was at the request of the BSRB. I know Representative Wolf Moore will recall I introduced it the other day through committee because I think there was a hiccup or something in the Senate side of it. So we will schedule that for hearing, but I'm just going to ask you, because you know I don't like to meet if we don't have enough work to get to work on, is I don't want to just schedule this for Monday. And that's the only thing that we have, because I don't think this is going to be that big of a deal. Just keep your ears open. If you're in doubt, just contact Dave, but he'll stay in communication. So if I schedule and know before we hit the floor, he's going to be sending you out emails, because I don't want to work any days we don't have to. So is this the only other bill that we have outside of the one that we kicked back yesterday? So we may have the possibility of 3 to 4 bills, depending on what the Senate sends us over. So hopefully we're done by Wednesday. That would be my goal on anything. But I don't want to schedule any meetings, so that's why it says meeting on call of the chair. So just take that serious. It's not like during the regular part of the session when she probably is kidding when she says that. So this here, I'm covering all my bases. So we are adjourned until whenever.
Until whenever.